thank you everyone for joining us for this session of reps. Just pulling up my notes here. So just a reminder that the Research Ethics and Policy Series lectures are all recorded, and we post the videos to our department's website when they're ready. We're really excited about our lineup for the fall and spring, which you can see on this slide here. Today, we're going to hear from Dr. Anna Wexler on the ethics of intraoperative neurosurgical research. And then in December, we'll hear from Noella Myers on research and rapidly evolving care during the COVID-19 pandemic. We'll share more information about our spring schedule as it comes together, but you can see we've got the first couple of months of spring 2021 slated. Just quickly before I introduce Dr. Wexler, I just wanted to flag for those of you who are on the call today that we have some online resources that are available through our Department of Medical Ethics and Health Policy. Mary Pham, if you don't mind, if you could just post the links to the COVID-19 materials, and then in a moment I'll ask you to post another link. What you see on this slide are a series of videos on ethics, policy, and COVID-19, which include videos on rationing, FDA drug regulation, public health measures, and more. So those may be of interest to folks on this Zoom. They're all available for free. And then we also have a series of short research ethics courses available for continuing education credit. The ethics of research with human subjects, which you see there at the top, can be used to satisfy training requirements at Penn and CHOP. And we have more specific details about how to go about doing that on our website. Again, all of these resources are free. They're not only free to the Penn community, but more generally, so feel free to share with others. And I would encourage you just to take a look at those to see what might be useful. Let me take a moment to thank our co-sponsors who make reps possible, as well as Mary Pham, who keeps all of these things running in good order. And now let me go ahead and introduce today's speaker. Dr. Anna Wexler is an assistant professor in the Department of Medical Ethics and Health Policy, where she's the PI of the Wexler Lab, which studies ethical, legal, and social issues surrounding emerging technology, with a particular focus on neurotechnology and do-it-yourself and direct-to-consumer medicine and science. She is a recipient of the 2018 NIH Director's Early Independence Award, and she received her PhD in 2017 from the History, Anthropology, Science, Technology, and Society program at MIT, where her dissertation centered on the DIY brain stimulation movement. So Dr. Wexler, thank you for joining us. I'm going to unshare my slides so you can go ahead and share yours. Please take it away.
Great. Thanks, Holly. Let me just make sure I have the slides up.
Great.
Slides look good? Okay, fantastic. So today I'm not going to be talking about DIY or direct to consumer, but this is related to brain stimulation in some way and the ethics of novel technologies. So today I'll be talking about a research study that looks at ethical issues in intraoperative neuroscience studies and sharing with you some empirical data from a collaborative study that we did. And I will say that we're about to submit the paper this week, and we're thinking about doing follow-up work on this project. So comments, feedback, all that is greatly appreciated, either during the talk or, if you have thoughts afterwards that you want to share, that would be very helpful. So before I get started, I'll acknowledge my collaborators and the people who worked on this project. This was a really interdisciplinary endeavor. So for medical ethics, health policy, myself, my research coordinator, Rebecca Choi, from the Department of Neurosurgery at Penn. We have a number of collaborators, including Gordon Baltuck, the PI on the project that I'll be talking about. From the neuroscience department, we have Josh Gold, and also collaborators at the University of Washington, Aaron Klein and Sarah Gehring. Okay, so I'm sure that most people don't know, or I should say maybe some people know what makes intraoperative neuroscience studies unique, but I think in order to describe them and to take a step back, to reflect on the distinction of these kinds of studies, it's worth talking about how neuroscientists, study the brain in general. So, scientists can take a number of different approaches, right? So there's cellular and molecular neuroscience, which looks at, neurons at the fine grain level. You can study, there's some studies of human neurons, brains in a dish, or brain organoids that you may have heard about. But you could also do studies of animal neurons. But these are not in an actual awake behaving animal, right? These are mostly in a dish. One can, or scientists can, study neurons in awake animals. That's an approach that some people take, but the number of neurons that you're looking at is quite limited. And in humans, it's hard to get inside the skull, right? Hard to get intracranial, right? To get inside the skull to measure neuronal activity is very difficult, right? So typically, if you want to study cognition, or if a scientist wants to study human cognition, they'll use neuroimaging studies or neurorecording that's outside the skull, right? So none of these methods looks at single neuron activity, single cell activity in an awake human, right? That's I don't want to say it's the holy grail, but it's a very unique opportunity when you're presented with that opportunity in the context of neuroscience to be able to do that kind of study. So there's not many studies that can do this. And really the only place where this has been done is in the operating room, essentially. So very famously, Wilder Penfield, who was a neurosurgeon, who operated on epileptic patients and also patients with brain tumors. He is known for actually creating some of the first brain maps. And so what he did was, while he was operating on these patients, so essentially, right, had their skulls open, he would stimulate their brains, partially or stimulate different areas, partially to see, exactly where to take out the parts of the brain. So sometimes in epilepsy, you actually resect or remove part of the brain. And for tumors, you also remove the tumor, and you might remove part of the brain as well. But he would stimulate around the brain to try and define these areas for resection. And in doing so, he actually then started stimulating other places around the brain and seeing what responses they elicited in the patient. So at the right there, you could see these are some of these brain maps, which are still in use today. That's one related to areas of vocalization. And I thought this line from one of his papers was really interesting, particularly given that this is a reps talk, right? So in general, stimulation was only carried, this is what he said. So in general, stimulation was only carried out in any operation when there is therapeutic justification for it. So, I don't think that line would pass muster with the IRB today. But this was, probably the most famous intracranial neuroscience research that has been done. And today, the vast majority of intracranial research, and I will say there's not a whole lot of it, is conducted outside the operating room, but actually also still in epilepsy patients. So in cases of severe epilepsy where a resection of part of the brain is indicated, what typically happens is that patient will come in, have surgery to place electrodes, usually on the surface of the brain, and then undergo, so these are temporary placement of these electrodes, the surface of the brain. The patient usually stays in the hospital for about a week of monitoring while the neurologists figure out where the seizures are coming from and what point in the brain they're actually starting from. And so during that week, there's a few scientists nationally who do studies of human cognition using these patients. So that's the extraoperative. So that's intracranial research in the extraoperative setting. I won't say this is common, but it's not uncommon, and it's been done for several decades now. What is less common, and what I'm going to be talking about today, is intraoperative research in the setting of implantation of a deep brain stimulator. And so this is an intraoperative setting. So this is while the surgery is actually happening. And there's, as I'll talk about in a moment, there's not many studies like this that have been done. But essentially what DBS is, or what deep brain stimulation is you could see there's an electrode that's implanted very deep inside the brain. So unlike in epilepsy, in the monitoring that I was mentioning earlier, right, there's an electrode array that's usually placed on the surface of the brain, not deep like this. And so there's a stimulator there. So that electrode actually provides low levels of electrical stimulation to the brain. It's connected to a stimulator or a battery essentially that sits under the chest there. That's the neurostimulator. An oversimplification is to describe it as a pacemaker for the brain. But DBS, deep brain stimulation, is a very effective treatment for Parkinson's disease and other movement disorders. It's been around for a little over 20 years. It doesn't cure those diseases, but it helps pretty dramatically with symptom relief. And so the process of implantation of this device requires opening up the brain and, again, inserting the electrode inside the head. So you have a setting where, you know, the brain is open. And they also, as I'll describe in a moment, they typically wake people up during the surgery, right? So you have a situation where the electrode's inside the brain, very deep, patient is awake. And you could, you know, some scientists have begun to do neuroscience research in that context. So there are an increasing number of studies that make use of these microelectrode recordings. So you can, you know, the electrode, the one that was implanted deep there, right, can be used to record data from neurons. And these are often done in the setting of deep brain stimulation surgeries for Parkinson's disease. There's been less than 20 studies of these that I've been able to find in the United States over the last roughly 2 decades. So they're not very common studies. But it is an area that the NIH Brain Initiative is really interested in funding. So this was a 2014 report, noted that specifically called out this context, right? Noted that individuals implanted with DBS provide a unique setting for researchers to study circuit function. And a more recent updated brain report also continues to emphasize this priority. And this report also recognized the importance of ethics. So assembling and funding specialized teams of researchers and neuroethicists is necessary to ensure coherence between experimental studies and clinical treatment approaches. And so there actually hasn't been a whole lot that's been written about the ethics of these kind of studies. It's really only in the last few years, I would say, that neuroethicists are starting to pay attention to these kinds of studies. And probably the most, you know, I mean, there's only a few papers on this topic, but the best or most comprehensive one, I should say, is by Winston Chong at UCSF, who outlined some of the ethical issues in these intraoperative neuroscience studies. And so I'm just going to go through a number of concerns that he's outlined. So first is undue influence. So he used undue influence in his first paper. In a later paper, he's moved to use the term voluntariness, right? So concerns about the voluntariness of consent when you have a surgeon that's part of the research team itself. And so part of what's really interesting, so this is one, you know, one potential issue. And I think part of what's really interesting about these studies is that they have some features of a healthy volunteer study in that, right, there's no expected benefit at all to the patient, and it's really just to gain neuroscience knowledge. I mean, there's some studies that are actually done in this context, you know, to study something related to Parkinson's disease, but there are other studies like the one, you know, that where we did our ethical supplement that I'm going to talk about in a moment, where, you know, it's really just to gain fundamental neuroscience knowledge. And these have been called opportunistic studies. So anyway, so there's some features of a healthy volunteer study here, right? But other features of a clinical trial. So it's not a clinical trial, obviously, but you know, in some ways it feels almost like it, just because you have this intraoperative setting and the patient population. So it feels in some ways like a hybrid, which raises questions about why patients are participating in these studies. So healthy volunteers participate in research largely due to financial incentives, but patients report participating in clinical trials largely due to altruism, so wanting to help, and expected therapeutic benefit. but there's been no work on why patients in this sort of hybrid study might be motivated to participate. Another concern identified by Chong in this paper was capacity, right? So patients with neurodegenerative diseases may have mild cognitive impairment, may have impaired capacity to consent to research. And again, here, this is a population with, right, until people make the decision typically to get deep brain stimulation, it's not a first line, it's when you failed other treatments. Or when they stop, they tend to stop working, or they're not working as well, right? The disease has already advanced, so there may be concerns about cognitive impairment. And finally, concerns related to informed consent. So do patients have adequate understanding of the study process? And do they have the ability to distinguish between therapy and research? So is there a therapeutic misconception going on here? So these have all been theoretical concerns. And we've had a really unique opportunity to actually empirically examine the extent to which these concerns play out in a patient population that is participating in an intraoperative study. And that came about kind of in an interesting way. So there was a call 2 years ago for a supplemental NIH funding for an embedded neuroethicist. And the supplement had to be to, of course, a parent project, and had to be a brain project. And the parent project was here at Penn, and this was a study that assessed intraoperative decision-making. And this was a collaboration between Penn Neuroscience and neurosurgery. And so the patient population here were individuals with Parkinson's disease who were having the deep brain stimulator essentially placed. And they were electing to either go unilateral or bilateral DBS placement. So depending on where one's symptoms are, you can have the stimulator placed on one side, or you can have it placed on both sides. And there's some people who elect to have just placement on one side initially, if their symptoms are only really present, or I would say giving them a lot of trouble and debilitating on one side, they'll just start with unilateral, and then maybe at a later stage, they'll have the second placement. And that's gonna be important later. So I just wanna flag that point there. So they undergo this operation. And so it's quite a complicated operation. But essentially, after they place the electrode inside the brain, they wake up the patient just to confirm that the placement is right. They turn on a little bit of stimulation. They just want to make sure everything sort of looks okay. So the patient's awake. The lead has been placed. They haven't closed up the wound or anything. What happens then is that the neuroscience team comes in, and essentially they just sort of switch computers, and the electrode recordings then go to the neuroscience team, and the patient performs a cognitive task for up to 30 minutes. And that's their time limit, so they don't go more than 30 minutes. And patients play a game, so they're either doing an eye tracking task, or another task they would do is a probability game using handheld buttons. And this was basically to look at decision-making at a neuronal level. That was the goal of this parent study. And so what we did in the supplement was, again, we had this opportunity to empirically examine some of the ethical concerns that had been raised in this context. And so we wanted to look at subjects' understanding of information presented during the informed consent process. So things like purpose of the study, the protocol, right? What was going to happen to them in the study, the risks of the study, and the potential benefits. We did want to assess understanding. I put recall in parentheses there because the way the study worked out was we actually could not assess understanding at the visit where the informed consent process happened. And so we ended up doing an interview, and I'll describe that in the timeline in a moment, but we ended up doing an interview a bit later. So this actually ended up being a bit more about recall than understanding. And we'll discuss, what that means later. But that was one of the main things we wanted to understand. We also wanted to get at their post-op reflections on the research task. And for voluntariness, and I think just more broadly motivations to participate, right? So why they're participating in the study, if people decline to participate, why that's the case, and again, their reflections on participation in the task. Okay, so in terms of the timeline, so this is a little bit complicated, and so hopefully this timeline will clarify it a bit. So there's three things going on here. One is patients are coming for their normal care, and that is this. I don't know if you can see my mouse here, but that is the DBS surgery, right? These are patients who are having DBS surgery as part of their clinical care. So that's happening. This is going to be a timeline, as you'll see, right? So that's their surgery. Before that, about a week or two of the surgery, they come in for a pre-surgical visit. They come to the neurosurgeon's office, and some of them drive from about 2 hours away, and they have a pretty long day. So they undergo all sorts of testing. They have various meetings with the neurosurgeon, with the nurse practitioner, ask their final, any questions that they might have. So this is a pretty significant visit for them. And so the parent intraoperative. Okay, so I said there's three things, right? So this is the clinical care. This is what they're doing. Then there's the parent study, which is the NIH study to assess the intraoperative decision making. And then there's our study, which is, so the parent study is the add-on to their clinical care. And then our study, the ethics supplement, is an add-on to the parent study. So this is the parent study timeline. So at this pre-surgical visit, they're recruited for the main intraoperative study. That's where the informed consent process happens, and they do a practice task in the office, a cognitive task. Really, the main data collection point of the parent study is intraoperatively during the surgery. So they complete this cognitive task as the neural data is recorded. And then our study was the ethics supplement. And so they're recruited for our study after they consent. If they consent to the parent intraoperative study, only then are they asked if they want to participate in the ethics study. If yes, they complete a brief questionnaire in the office. The main 2 points are preoperative and a postoperative interviews, the main two features or data collection time points of our study. And so there's about a week after the pre-surgical visit is when we do a preoperative interview. This is again for the ethics study over the phone. So this happens about a week after the pre-surgical visit, so a week after the informed consent, and a little less time, a little less than a week prior to the surgery. And the post-op interview happens about 5 weeks after the surgery. So that's the timeline. I hope that's at least somewhat clear. So methods, we went over timeline and recruitment. And so I should say the recruitment is done by the pre-surgical visit is done by the same research coordinator who recruits them for the parent intraoperative study. So they're offered a $75 Amazon e-gift card for each interview for both the pre-op and the post-op interviews. They are not offered any compensation for the parent intraoperative study. And again, they only find out about the ethics study if they've already agreed to participate in the intraoperative study. For subjects who declined to participate in the parent study, they were offered a $5 Amazon e-gift card for completing a brief questionnaire. We had the pre-op interviews, looking at motivations for participation and recalled information during the informed consent process. Post-op was just really reflections on their experiences during the surgery and reflections on participation in the research study. We had interviews recorded and transcribed, and they were coded both by myself and Rebecca Choi, my research coordinator. I guess if there's any questions on, before we get to the results, if anybody has any question on methods, I'm happy to take those. Mary, just feel free to interrupt me if anyone.
I don't see anything in the chat, but we could pause for a moment if folks want to raise their hand. Oh, Steve has a question. Steve,
sorry, just having trouble unmuting there. Anna, one question, maybe you were going to get to this, but in terms of recruitment for the cognitive study, the parent cognitive study, who is doing that recruitment? Is it a member of the, and I'm sorry if you said this, but is it a member of the cognitive neuroscience team, or is it somebody affiliated with the neurosurgeons, or who's doing that?
Yeah, good question. And I know that's relevant to work. I know Emily was working on this. I can't remember if Steve and Holly, if you were part of that project, but so no, I did not mention it. So that's actually done by a research coordinator. And so what happens is The neurosurgeon himself does not mention the study. There is a nurse practitioner who also meets with the patient, and what she does is she gauges initial interest, like, is this something you'd be interested in doing? If the person expresses some interest, they're then set down to meet with a research coordinator. So it's still in the neurosurgery department, right? They're not leaving that, but it is a research coordinator who does the actual review of the informed consent form with the patient. And yeah, that's how it happens.
Thanks.
And that's actually, yeah. Does that answer your question?
Yeah, it does. Thanks.
But I will say that, you know, in interviews, they felt that the participants did feel like it was the neurosurgeon's study, and they said things to that effect. But anyway, we can discuss that a bit later. So study flow diagram here. So there were 30 eligible patients. 2 were excluded by the clinical team due to severe age and anxiety. So they were actually, the nurse practitioner decided not to even approach them with this, you know, to gauge their initial interest. They were not recruited at all. So there were 28 who were invited to participate in the study. 4 declined to participate, and I'll talk about why, but it was primarily due to health risks of increased surgical time. So 24 participated in the intraoperative study, and those 24 were invited to participate in our supplement. 2 did not complete a preoperative interview. 1 declined to participate. 1 was excluded due to language barrier. So we had 22 pre-op interviews. We had 2 people not complete the post-op interview. 1 declined to participate. That individual thought he was going to get paid for the main intraoperative study, but he was acting a little confused, and later ended up he had some complication from the neurosurgery, actually. And 1 patient actually just canceled the surgery for unknown reason. So we analyzed 22 pre-op and 20 post-op interviews. Here's a table of demographic characteristics. So far more males here than females. There are more males, you know, Parkinson's is more common in males than females. Age, about 61. Time since Parkinson's diagnosis is 9 years. Education seems pretty varied. Household income also. And here it's interesting to point out, because we're going to come back to this, that 3 individuals had a prior DBS implant on one side, and they were coming back to get the other side done. And all 3 of them had had the initial operation with the same neurosurgeon in his office. Okay, so coming to some of the results. All right, so reasons for declining to participate in the parent study. So everybody mentioned health concerns due to increased risk of surgical time. And I'm going to get to risk a bit later, because that's, yeah, we'll discuss that a bit later in the results. Other concerns were feeling overwhelmed by the surgery and potential discomfort due to additional surgical time. So in terms of why people participated in the study, so all cited altruism, so helping others, specifically future Parkinson's patients, or advancing medical science is very important or important in their decision to participate. Most also agreed that trust in the clinical team played a significant role in their decision to participate. All reported feeling like they have freedom of choice in participating in the study. Again, this doesn't mean they have freedom of choice, but they did all, you know, nobody, I think it's worth mentioning that in response to this question, nobody said, yeah, I felt compelled, or I felt like I had to. And this was interesting, and actually Steve's question helped clarify this, which is useful, right? So we also asked participants, this is sort of just a side note here, we asked participants when they made the decision in their mind to participate in the research study. So whether it was before the informed consent process, when the nurse practitioner was gauging interest, and the nurse practitioner was a female, and the research coordinator, there were 2 of them, they both happened to be male. So it was actually useful in data analysis, because if they said, well, when she first asked me, that, you know, we took that to mean the nurse practitioner. And another 6 reported deciding right when they were asked or instantly. So this is just interesting because there's other work showing that just context plays a huge role in whether or not participants decide to participate in research, right? So the setting itself and the trust that people have in the research team rather than the actual content of the study and the information that's presented in the consent. So so the 3 patients that had prior experience with the neurosurgeon for unilateral DBS, these patients were really interesting. So I can't remember if I mentioned this earlier, but one very interesting thing about DBS is that the effects are really quite dramatic. If you haven't seen them before, I encourage you to Google it on YouTube. I'm sure you could find like a before and after, but you see patients with really, really bad tremor, like trouble walking, can't hold anything. And then after DBS, they just look fine. I mean, it's quite a dramatic, surgery that has a really large impact on patients' quality of life. So I think that's just worth keeping in mind for these results. So of the 3 patients with prior experience with this neurosurgeon, 2 of them reported wanting to give back to the neurosurgeon in some way. So here's one quote: "Since Dr. X improved my life for 4 years, anything for Dr. X. I understand the whole entire study. He's in charge of it." Again, Steve, that sort of speaks to the point of who's doing the consent and what people think about. I mean, that's kind of a side note, right? But even though it's from the research coordinator, right, they perceived this to be the surgeon study, which it was. But anyway, the main point here is, right, this sense of gratitude and wanting to give back to the neurosurgeon. This is from another, the second patient. "I'm going to do it because I want to help Dr. X in any way I can and try to give back to what he has done for me." Okay, so post-op reflections. So a lot of people, well, some people didn't have memory of the surgical experience. So 3 of the 20 subjects who completed the post-op interviews had no memory at all of the surgical experience and no memory at all of performing the research task, but they did perform the task. So for the remainder, recall was often really hazy. Subjects, recalled fleeting memories as if they were in a twilight dream state or a very deep fog. Again, they're woken, right? So at the point where they're woken up from the surgery, they've previously been on, anesthesia drugs, right? Because the neurosurgeon has, essentially been drilling into their head. So, they're pretty drugged up at this point. So it's not a surprise that they have these recollections as, very hazy. But of the ones, who did remember, even if it was hazy recall, 13 said that they felt like the boundaries between the research and the therapeutic components of surgery were clear. For the remaining 4, they felt like the entire experience was blurry. One subject said, "I grabbed hold of something. I'm not sure that was part of it. The study, I really can't remember that much." And so that we'll come to that in discussion, but that's, to what extent we want these subjects to have a distinction, right? To be able to distinguish between research and therapeutic components. But again, they're under a lot of anesthesia here, so we wouldn't necessarily expect them to be able to, distinguish very clearly between the two things. In terms of their reflections on participating in the study, so all those who had memories of the experience reported that they were happy to have participated in the study. And then as I was doing the interviews, I was actually the sole interviewer here. People, and I'll talk about this in a moment, but people began reporting that they were participating in the study, for Parkinson's disease, to help advance knowledge about Parkinson's disease, and to help others, right? So I started adding in a question, which is why it's not n = 20. I asked them, even if the study was, even if the aim of the study was solely to advance basic understanding of brain function, would he still have, and not help Parkinson's disease, would he still have participated? And everybody who was asked said yes. All right, so I'm going to come again to some of these points in the discussion, but I want to move to understanding, and again, we ended up assessing recall of the informed consent. And so just, the brief bullet points, and I'll go into the details of these, in the next slides, but 36.4% correctly remembered the study purpose as being related to neuroscience, 50% correctly remembered study protocol, 36.4% correctly recalled benefits, and only 22.7% actually recalled the risks of the study. So recall was not great across the board. And again, I'm going to come to what they responded and how it was coded, and then discussion. We'll talk about why this may have been the case and whether it matters. I will say there was no clear demographic patterns, differences between good recallers and bad recallers. Okay, so study purpose. So this was the line from the informed consent. So study purpose was to better understand how activity patterns of neurons in various structures in the human brain contribute to higher functions like learning and decision-making. And so the way these questions were framed when I was asking them, we had to frame them gently. So it was, before I get to that, so the question was, do you remember what the study team told you about study purpose or something? I think I'm screwing up a word because these interviews were done a while ago, but there was the question, do you remember, not what is the purpose of the study? Because we found that phrasing actually provoked some anxiety in people, especially since they really, as it became clear that these individuals were not remembering very well. This was also, just 5 days essentially, or less than a week before a major surgery. So it was framed kind of gently. So do you remember what the study team told you about the study purpose? So 36.4%, 8 people said, said it was neuroscience related. That was the one. The bold here is what we coded as correct. So, and here are just some example quotes from each code. So I think they try to learn how people think, how people's brains work. So that was coded as neuroscience related. Other folks remembered task, but not purpose. So they said, there was some kind of procedure where they can look into your eyes and read some of the responses that were going to happen. Some people didn't remember. Two people thought that one of the goals was to help future patients that have Parkinson's. And then there was just, some people who were, we just coded these as other, it was just other responses. Like it was just to see if I lost any cognitive ability during the course of this process, which, is not correct. So that was study purpose, study protocol. So we asked again, what if they remembered what was going to essentially happen to them. So this is, sorry for flipping back and forth there. So this is what it said in the informed consent. You'll undergo cognitive testing at your pre-op, intraoperative, and post-operative visit. They actually didn't typically undergo testing at the post-op visit. Additionally, you'll undergo microstimulation and neural recording to your intraoperative visit. The team actually dropped the microstimulation point later. So in terms of what people remembered, we had 5 people don't know, remember, wasn't mentioned. I don't remember, yeah, as you can see here, I don't remember them saying that. 11 recalled aspects of the cognitive task, and we coded this very generously. So they said, one person said the light goes on, the light goes off, and you push the 2 things on the pad they give you to push a button on. That was actually, I think, one of the more coherent memories. So, typically people could not elucidate what was going to happen to them during the process. So, even if they got one element, or one main element of what was going to happen, we coded that as correct. Or some that we had to code as unclear. It's easier, this is one example, it's easier to pinpoint the spot, I guess, in the brain that they need to use to fulfill the procedure. And then there was 2 people who just misunderstood the protocol, right? During the awake part of the procedure, I will receive some questions. All right, we have risk and benefit, and then that's it. So the risks of the study. So this is language from the informed consent. There's a potential loss of confidentiality associated with your having your chart reviewed. Also, this research proposal will extend the intraoperative collection time of microelectrode recordings for up to 30 minutes. The increased surgical time required to perform the task may increase the risk of infection. So this was the phrasing. Do you remember if the study team mentioned anything about study risks? So don't know, remember, or was not mentioned. That was the majority. Don't remember them saying anything about any type of risk. 2 people said that there was no risks, right? What I recall was there are no risks. 4 people remembered the surgical risk, and 1 recalled loss of confidentiality. And here too, when you think about risks, there is no, it's hard to pinpoint what the risk actually is in numerical terms. And there actually is, I haven't seen any data exactly on what the increased risk here might actually be. So, but I mean, the main point here is that risk, this was pretty surprising, at least to me when doing the interviews, that the recall of risk was that low. And then the last recall slide here is recall of benefits. So informed consent, you will not benefit directly from the study. It is hoped that information learned from the study may benefit other people with Parkinson's disease in the future. And this line is really interesting. And there was some disagreement even amongst the PIs of the study about the meaning of this line. So on the one hand, again, this study was really to gain fundamental neuroscience knowledge about cognition, about flexible decision making. Its goal was not to, help improve Parkinson's disease, help improve the treatment or understanding of Parkinson's disease, I should say. And so when I was going over some of these results with one of the postdocs on the study, he was surprised to learn that this line had been included on the informed consent. He said, oh, that must have made its way on just from like a previous form or something. But the PI of the study said, no, that's right. Any information about the brain that we can learn, right, will in the future help other people with Parkinson's disease, because any neuroscience knowledge can contribute to a better understanding of a neurological disease. Anyway, so that's interesting because the recall, what people recalled from this was sort of a bit all over the place. So, right, so people, only 1 person said that they would not benefit directly. 12 people didn't know or didn't remember. Helping others was a response from 2 people. Advancing science, we coded as benefit, right, which was correct. So just to get a better understanding of brain function, both helping others and advancing science. I hope it will help patients in the future and help doctors understand how our brain works so they can help the future patient better. And then there was other. But this is, and we could come back to this maybe in the discussion, but the point of how the study is framed, I think is quite interesting. Okay, so going through some of the results, right? So even though the research team completed thorough training, and I should say, we've been interacting with the research coordinators who have been doing informed consent, I observed some of the informed consent processes, and at least from my observations, they were very thorough. So I don't think this is a case of it not being being a quick or not a good recruitment process. Not a comprehensive recruitment process. I mean, my impression was that the team was very competent, but still participants demonstrated poor retention of study information. So, right, so how does this compare to previous studies? And so we did do a dive into the literature to look at other studies that have assessed recall, particularly in Parkinson's patients, being consented to research or consenting to research. But the methods were just all over the map, essentially. And so I used to have a slide on for all these, like comparative figures for all these, the protocols, the study purpose, risks, and benefits. We have that information, but it's the degree to which it's a valid comparison is an open question, because there's so much variation in the kinds of trials that are being assessed. So some studies were looking at hypothetical vignettes, some are doing looking at pharmaceuticals, some are doing experimental devices. So it's all over the map with regard to the kinds of trials, when recall was assessed. Is it the next week? Is it 2 years later? How it's assessed. There are some that are open-ended interviews, some that are multiple choice questions, some that are take-home surveys, some that say, did you feel informed about the risks? So, and obviously they don't have to mention the risks there. They could just say, yes, I felt informed about the risks. And then how the correct responses, excuse me, were coded and reported. So there's a lot of variation. So I will just show the risk slide. So this is our study. We had 22.7% correct recall of risk. I really don't want to spend too much time here, but you could see even on, just because I just feel like it's comparing apples to oranges. But you could see here, we're on the low end, even for other studies. This is correct recall of risk in previous studies assessing this in Parkinson's patients in a research protocol. But again, you can see here, this is a take-home questionnaire. This is a study asking patients whether they felt informed about risk. And we can come back to that if we want in the discussion. But yeah, this was something tricky that we had to deal with in the discussion and in the write-up of the paper. Okay, so why was there poor recall? So first of all, I think there's a lack of saliency going on, right? So these people have decided to take the plunge and have this really major neurosurgery, and that's what's on their minds. And it's very, these individuals are anxious and justifiably so, and this is what's on their mind. This is this visit, right? This pre-surgical visit where the informed consent process happens. That's their last time. That same day, right? They're talking to the neurosurgeon about any last questions that they have. The pre-surgical visit is a really long and taxing day. Again, these are not healthy individuals. These are patients who've had this pretty debilitating disease for, right? We saw a mean time of 9 years. There could have been cognitive impairment due to Parkinson's disease. Again, this is a disease that has progressed for a significant amount of time before they have elected to have the surgery. The main question here, and I'd love to hear your thoughts either at this discussion or later, right, is like, so, okay, poor recall, how much should we care, right? This is not equivalent to an assessment of capacity, right? So, we probably would not expect people to have perfect recall. We definitely would not, we definitely would not expect them to have perfect recall. Do we want them to have good recall? Maybe, but it's not equivalent to an assessment of capacity in the office at the same time that the informed consent process is happening. So it's entirely possible they had, great capacity during the consent process and then just forgot later. It's also possible they didn't have, great capacity or had some impaired capacity, during the informed consent process. And then that's reflected, in the poor recall. So I think that's the main question is what this means and how much we should be concerned about this, right? And to that point, Jason Karlowicz has done some work in this area, and he's shown that while cognitively normal Parkinson's patients score well on capacity measures, right? When you start to see more cognitive impairment in patients as measured by, different neurocognitive measures and scales, right? They tend to start declining on their capacity measure. So fewer of those with borderline impairment and even fewer of those who were judged to have impaired cognition were capable of providing informed consent. Which raises the question of what was the neurocognitive capacity in our population. And we're working on getting that data now. It was not in our initial IRB, so we do need to submit a modification for that. So anyway, this is an open question, the relationship between recall and capacity. Okay, I know we have 10 minutes left, so I'm just gonna go through the rest quickly. So interestingly, no one had a therapeutic misconception. No, so nobody said, this is gonna benefit me or I'm hoping to benefit from them, which is great. Subjects did participate out of this desire to help Parkinson's patients and Parkinson's research. Again, even though the point of the study was to gain fundamental neuroscience knowledge, again, likely due to that line in the informed consent. So this could just be, this very reasonable interpretation from this line in informed consent saying that the information gleaned in the study would help benefit Parkinson's patients in the future. It could also be due to the social context of recruitment. So even if that line wasn't there, it could just be that they're in the, they're getting recruited for their study from their neurosurgeon's office. They could, still have this conception that the study was to help Parkinson's patients. It is very interesting that all subjects would have participated, even if they were told the study purpose was related to brain science and not Parkinson's disease. And I think that does bode well for this sort of research. And just, it was my impression that participants actually, you know, they're so disabled in their other areas of life that they were actually happy to have the chance to contribute. That was just my impression from the interviews. You know, in terms of the participants who said, you know, they wanted to give back to the neurosurgeon, right? One question is, you know, should we be concerned about voluntariness? I don't know. I saw another word used recently, which was indebtedness, which I thought may be a more apt description of, you know, of the sentiment expressed by these patients. And again, all patients reported they had free choice to participate in the study, and the 4 that declined due to concerns about increased health risks. Again, this doesn't say, you know, whether or not it was truly voluntary. I'm aware of that, but I think it's worth mentioning that, you know, it's worth noting that nobody, you know, said that they felt compelled, and people did feel, at least some people felt, you know, had the ability to decline. Okay, so limitations of the study, smallish sample size. Again, we're not going to get much larger sample sizes. This is, you know, these intraoperative studies do not have huge numbers of subjects. The cognitive abilities of Parkinson's patients fluctuate based on medication intake. So this potentially could have impacted recall ability. Although it was our impression that, you know, we did telephone interviews that they were generally scheduled when people were sort of at their best. Some people expressed that, you know, requested a specific time because they felt like they'd be sharper then, essentially, based on their timing of their medication. Okay, so future work, and I'd love to hear your thoughts again, either here or later, right? So there's been a movement, you know, not a movement, but other neuroethicists have begun talking about, you know, how we can, you know, is there a way to enhance informed consent? And other neuroethicists have not been talking about this. So they've been talking about the next one, which I'll skip to and then come back to the first one. So better guidelines for recruitment and consent in intraoperative studies. There's really no guidelines here about how recruitment and consent should be done in intraoperative studies. And there's a Target article that just actually went out in A-Job Neuroscience. It's open now for peer commentary, essentially about this issue. It was an interview study of PIs running intraoperative neuroscience studies. And they found that, you know, there was a lot of variation in both recruitment and consent. Coming back to the first point, you know, should we think about interventions to enhance informed consent and information retention within this subject population? Again, do we care about recall, right? A lot of that hinges on that aspect. Obviously, right, interventions to enhance informed consent is a huge area of research, and I'm aware of that. And then in future work, right? So I think one of the main downsides is of the studies, we don't have comparative recall figures, right? So what would, you know, what would we expect a similar population to be able to recall? So we are thinking about doing some follow-up work here. So that could be a potential area of research. And I know I've left almost no time for questions. So sorry about that. But if there's any questions, I'd love to hear them. And again, you know, feedback via emails also would be appreciated.
Great, thank you, Anna. And if folks have questions, you can either put them in the chat or use the raise hand function, and I can call on you that way. Anna, in the meantime, while people are thinking, you know, what strikes me about your participation in the parent study is how were you able to negotiate with the PI when you were actually doing something that was kind of sensitive, right? Which is identifying that perhaps people who are participating in their study really didn't have a great understanding or recall of some of these ethically challenging concepts. So maybe you could share a little bit about whether there was any worry about that or what that conversation was like for those of, you know, ethicists who would like to work with trialists. That's an important question.
Yeah, so I should say it was a cold email approach. No, actually, Jonathan Moreno wrote a brief introduction, so that was the intro. But still, it was, you know, I didn't know this PI, and our initial conversation was over the phone, and there was a lot of skepticism, I would say, about what we were doing. But still, there was openness, and so I think it took a while to build the relationship, and there were some tenuous parts of this, like. We presented some interim results at a Brain Initiative meeting about a year ago. And that was the first time I was presenting a result, and the PI was there. So even at that time, I was still like a little concerned about what he would think. But he's been, this is the neurosurgeon. He's been very supportive. But it was definitely a little touch and go at the beginning.
Okay, we do have 2 questions that are coming in via chat. So the first is from Don London, who asks the tone of the delivery of the consent information during the consent process and how questions are answered about risks and benefits can have an impact on comprehension. Has there been consideration to assessment of the process and time allocation for discussion versus just, sharing the language of the consent?
That's a great question, and I don't know the answer to that. Yeah, and I'm just trying to think back to what it was like when I was observing. It seemed like the time is shorter, that the risks were presented, but it didn't feel like it was glossed over at all when I was at least observing. It wasn't like, and the risk might be this. It felt like, here are the risks. Do you have any questions? I don't know. There's a huge literature on ways to potentially improve informed consent that maybe people here know more about than I do. So I don't know, but that's a very good question and a good point.
There's another question that relates to the revised common rule, which requires a concise summary of key information at the beginning of informed consent. And so there's a question about whether that new form of consent was included for this study.
That's a very good question. I could pull that up and find out. I don't remember offhand.
One of the goals of that concise summary, of course, was to try to encourage people to pay attention to the most salient bits of information and potentially to improve recall of those most important bits of information. But there's been a lot of debate about how do you decide what's most important? It's phrased as what would a reasonable person want to know? How do you know what a reasonable person would want to know without kind of asking them? So I think that's why the question is being asked here. You might be able to kind of get some assessments depending on what type of consent was used.
Yeah, I can tell you when the recruitment was done October 18th to February 2020. And so I observed on the earlier side of that. Would the new form have been?
Yeah, it should have been included.
Mm-hmm. So then if it was probably included. I mean, they were, this was a very good study team, I would say.
So Emily Largen adds in response to Don London's question that discourse analysis could be an interesting method for future studies, allowing you to analyze the naturally occurring consent conversation.
I think Pamela has done some work on that. Pamela Sankar has done some work with audio taped informed consent that she published, I think, 15 or 20 years ago. So there is some of that exists, but I personally don't know the literature very well. But there's a lot of other discussion of how to present the topics of informed consent better, right? So yeah, using pictures, more white space, graphics, that sort of thing. So I think that could, that something like that could help. I mean, I think for me, the main, I understand why they wanted to do the consent during the pre-surgical visit, because that's the time that you have the patient in the office and that's the time you can speak to them. But yeah, I just wonder if separating the informed consent, or at least maybe doing some of it and following it up later in some way, separating that process, I think would have helped, because patients really seemed exhausted at that time.
All right, well, we are at time. Thank you, Anna, for presenting your really interesting research. And thanks to everyone for joining today. And we will hopefully see you again next month, which will be our last reps for 2020, which is kind of amazing that we've already reached the end of the year. Thanks, everyone.